Hi, this is Jen Livingston for the Unit 2 video case study. Who is the patient, including demographics, epidemiology, and risk factors? What is the clinical syndrome sign and symptoms? And what is the time course or pattern for the signs and symptoms? So, a 68-year-old Asian male with a past medical history of seasonal allergies and current cigarette smoking, which are both risk factors, with bilateral red eyes with clear discharge, mild headache, low-grade fever, sore throat, nasal congestion, and a feeling of fullness and popping in his ears. He complains of a subjective fever. He denies changes in weight, appetite, or thirst. He's got a mild headache, a sore throat, nasal congestion, feeling of fullness and popping in the ears, denies ear pain or drainage, redness to eyes for 3 days, but denies pain, crusting, and endorses clear discharge to the eyes. Denies history of ocular trauma or vision changes. This is all on ROS. He denies falls. He denies weakness, numbness, and dizziness. Medications, he's taking lisinopril, atorvastatin, diphenhydramine for seasonal allergies, ranitidine, sometimes for reflux, and hydroxyzine, sometimes for itching. He has an allergic reaction to penicillin, which is hives. Past medical, seasonal allergies, hypertension, hyperlipidemia, gastric reflux, and peripheral artery insufficiency. Social history, current cigarette smoker with a 50-pack year smoking history. Drinks 1 to 2 beers a night, 4 to 5 nights a week. On physical exam, his vital signs are 179/89. His heart rate is 101. His respiratory rate is 21. He's 93% on room air with an oral temp of 38 degrees Celsius and a BMI of 38. So Perla, extraocular motions intact. Mild arrhythmia to oral pharynx without exudates or swellings noted. He's got no pain with manipulation of the pinnae or tragus, and he's got swollen nasal turbinate. I don't know which side. No cervical or preauricular adenopathy was noted. Heart sounds S1 and S2. And that's all we've got for our subjective and objective. So my differential is adenovirus, rhinovirus, and seasonal allergy exacerbation. My assessment is that we have a 68-year-old Asian male presenting to the ED with acute onset redness to bilateral eyes, fullness and popping in ears, sore throat, and temperature of 100.4 degrees Fahrenheit. Past medical includes seasonal allergies for which he takes diphenhydramine. Patient is likely suffering from a common cold and requires tobacco cessation counseling. So my plan for the common cold is that first-line therapy is non-pharmacologic and includes rest, increasing fluids, including juice, water, and tea, utilizing saline gargles, and nasal irrigation. Should this patient desire pharmacological intervention, I would utilize an over-the-counter such as Afrin for a max of 3 days to prevent rebound congestion per Arcangelo 2017, and I would utilize over-the-counter cough drops to soothe the sore throat. And then using a symptom complex approach, my differential diagnosis includes rhinovirus, adenovirus, and allergies. I think clinical experience is a very important driver of the ability of the clinician to reach into a reservoir of knowledge affirmed by experience to generate an efficient yet thorough and informed differential. The more you know and the more you see, the stronger and more extensive the neural network supporting your knowledge. My 2 open-ended questions are, where would a lack of falls be best placed on the review of systems? And are there any red flags or do not miss within the symptoms complex as presented? Thanks.